Hi, Mike Gibson, Philippe Genereux, coming to you live from TCT 2024. We're here talking about the early TAVR trial, doing TAVR in those patients who are asymptomatic but have severe aortic stenosis. Really exciting to hear what you have to say, Philippe.
All right, first, thanks for having me. Very exciting time. So we conduct the early TAVR trial, and I have to say that I had the chance to work with a great team. My co-PI, Alan Schwartz, my chairman, our chairman, Marty Leon, and a lot of 75 sites in US and Canada. So the early TAVR trial really tried to answer the very important question that cardiologists are facing every day, whether early intervention with severe asymptomatic aortic stenosis will be superior to a watchful waiting strategy, which the guideline recommend. So we know that aortic valve replacement, whatever TAVR or SAVR, is indicated for patients with severe AS with symptom or low ejection fraction, but there's still no strong evidence for early intervention with either TAVR or SAVR. There were two small randomized trials, the recovery trial, 150 patient approximately, and the Avatar trial, also 150 patient, that showed that in young patient around 65 years old, early surgery was associated with improved outcome. But no trial so far have been conducted with TAVR. So that's why we elect to do this large randomized trial, more than 900 patients, 65 years old and above, investigating whether TAVR with the balloon expandable valve, SAPIEN 3 or SAPIEN Ultra, will be superior to surveillance in terms of death, stroke, and unplanned cardiovascular hospitalization at a minimum of 2 years follow-up.
And what did you find?
Well, we found that, as a matter of fact, the strategy of early TAVR was superior to clinical surveillance at a mean follow-up of 3.8 years, was superior in terms of death, stroke, and unplanned cardiovascular hospitalization, with approximately 50% reduction in the primary endpoint, and a number needed to treat at 2 years of around 6 patients to avoid one event. When we look at the composite of the primary endpoint, there is no difference, no strong difference in terms of all-cause mortality. There is a very interesting benefit, so a lower rate of stroke in the early TAVR arm compared to clinical surveillance, and this difference was increasing through time, was numerically superior with early TAVR, but not reaching statistical significance. And obviously, there was an early benefit in early intervention in regards of unplanned cardiovascular hospitalization, which was very obvious within the first 6 months of the trial and was sustained throughout follow-up. We also look at different version of the primary endpoint, the combination of death, stroke, and heart failure hospitalization, for example, which also show similar result with approximately 40% reduction in the primary endpoint. And also we look at another very, I would say, interesting endpoint where we took the composite of death, stroke, unplanned cardiovascular hospitalization, but also, I would say, conversion to AVR due to very severe advanced symptoms, such as syncope, heart failure with pulmonary edema. We also show a superiority of early intervention compared to clinical surveillance. So I think across the board, early intervention was superior to watchful waiting among the population of our study.
And were there any subgroups that had disproportionate benefit where there was a positive interaction p-value?
So we, on all the pre-specified subgroup, whether it's age, gender, peak velocity more than 5, there was no interaction. So there's a benefit across all the pre-specified secondary endpoint. Our study obviously were, I would say, a TAVR population. The mean age was 76 years old. So the patient were above 65. So 76 years old was the mean age. We had 8 to 9% bicuspid that were suitable for TAVR. And which is a very strength of the trial. I would say that more than 90% of the patient at baseline had a negative low-level stress test. So they were really a thorough population of severe AS with no symptoms. So reassuring in this regard. Yeah.
So does this change practice, Philippe?
Well, we'll see. Right now we have 2 trials with surgery that show benefit of early intervention. I would say in very severe, so critical AS, or severe. So young patient, 65 years old, suitable for surgery. I think we had data to support that. And now with early TAVR, I would say that we have clear benefit of early intervention with TAVR balloon expandable valve. So I would say yes, definitely. Right now, there's no clear indication for TAVR among those patients in the guidelines. So I strongly believe that this will translate into a change in the next guideline. We'll see. And we also have another trial coming up, the EVOLVE trial, which is led by Mark Dweck. So I think the totality of the evidence will point toward a change in the guidelines. We will publish soon a meta-analysis of those 4 trials as well. We're going to present at TCT. Also showing a clear benefit actually to prevent hospitalization for heart failure, a benefit actually to prevent stroke. So we know when we intervene later, we wait, we become more high risk, maybe more thrombogenicity, and there's a clear signal into increased stroke, which is interesting, but still need to be validated. But I think the totality of the evidence show that there's no downside actually into early intervention, especially in the 76 years old population, where the one point we didn't discuss, but the crossover, I would say the conversion to symptom occur very quickly. 25%, 26% convert to symptom within 6 months, 50% convert to symptom within 1 year, and up to 70% within 2 years. So with the vast majority of the patient converting within a year, waiting to symptom, it's probably not necessary. So better to plan in advance. And in the early TAVR trial, we were very good in planning in advance. Everyone had a CAT scan first. Everyone, we knew the plan. So when they convert to symptom, quickly they were treated with TAVR, which probably explain also the lack of benefit and mortality that we show with surgery. So when you quick to convert patient with a less invasive therapy such as TAVR, you don't pay the price of mortality, but you pay the price on hospitalization for heart failure. And potentially at 5-10 years, we're going to see a signal of mortality, and that's remained to be seen. I think those data are very exciting, and we'll see how the guideline will react to this.
Congratulations. Great job. Thanks for sharing with us today. And thanks to all of you for joining here live from TCT 2024.
Thank you so much, Mike.